the management of blood transfusion. It's something which a surgeon is always interested to hear and understand. And today we have Dr. R.M. Jaiswal sir, who is the professor and director of blood center and flow cytometry and transplant immunology lab at Mahatma Gandhi Hospital. He is a passionate learner, working for safe, advanced, integrated transfusion services. He's a hard worker, still sitting in his chamber, what I can get. And he has developed a state-of-art transplant immunology lab here at Mahatma Gandhi Hospital. He is a vice president to International Committee of the American Society of Histocompatibility and Immunology. He is active member of many societies and have been awarded by various agencies. He has lots of publications, almost like 32 in national and international journals. And the when we talk of research specialization, the areas of his interest are apheresis, cellular therapy, transplant immunology, flow cytometry, and molecular, that is hemato-oncology cases. So I invite Dr. Jaiswal sir to take over from here and tell us when and how to transfuse blood and what could be where done best to these patients who are post-surgical, who needs blood transfusion, and when a surgeon can actually withdraw or can look for the cause not to transfuse. Over to you, sir.
Thank you. Thank you for nice introduction, Dr. Anand. First, I would like to give special thanks to Dr. V.K. Kapoor, sir, for organizing these kind of events, because these kind of events are very important for everyone, especially all the surgeons. Can I share my screen right now? Just you shift to my...
Sure, sir. You can.
I am not getting the this screen share option right now at present.
Okay.
Previously it was, but right now I'm not getting screen sharing option at this moment.
Yes, sir.
Okay, thank you, Dr. Anand, for nice introduction. And first, I would like to thanks Dr. V.K. Kapoor, sir, Dr. Anand Nagar for initiating this kind of event, because blood product management and transfusion triggers, especially for the surgical patient, are a very important aspect. So, today agenda will be how we are dealing in the blood transfusion services, what are the blood management program and patient blood management. This is a newer concept at present, and what are the massive transfusion protocol and transfusion triggers and current recommendation. Recently, JAMA released recent recommendation for the RBC transfusion, and I'm going to discuss those important points. Blood transfusion services. First, we wanted to know the primary focus. First and most important is the improving blood safety, emphasis on voluntary blood donations, program blood donation screening technology, and safe and judicious use of blood components. And at present, most of the transfusion services are involved in the therapeutic procedures, just like a therapeutic plasma exchange and for sensitization of ABO in compatible renal transplant. So these are the important area of blood transfusion services at present. And when we are talking about the transfusion, so first we need to remember some bloody facts. The main concept of this: be aware and beware of all the transfusion. There's a very common dictum in transfusion medicine: best transfusion is a no transfusion. And transfusion, as we know, these blood products are dealing with a very dangerous drug. So we should avoid. First, we should screen all our patient for the judicious use of blood and blood component. Then we can give the transfusion. And though it is commonly known as a blood transfusion, but literally we are dealing with the blood as a tissue, and you can say we are dealing with the liquid transplant. Transfusion are double trouble for hospital acquired infections. Blood shortage should be in the driver's seat of the decision making. And again, blood costs are the tip of the iceberg for the total cost of transfusions. And its implications for complications are clinical, economical, medical, legal, and ecological also. When we are talking about the transfusion...
Sir, sorry to interrupt, sir.
Yes,
just make it in PPT mode, sir.
Okay.
Click on the right.
Now
Yeah.
is it clear?
Yes.
Okay. So when we are talking about the blood transfusion to save blood, save lives, not only by the transfusion. Right now, there are a lot of concept is coming. Transfusion are one of the most overused treatment in a modern medicine at a cost of billion of dollars. And researchers are working on it. And recently, WHO also launches the program of patient blood management. And when we are talking about the process of the transfusion services, first, we need to generate the requisition, then donor screening and counseling. These are the internal process when when you are sending the request for the issuance of blood. There are a lot of process behind the issuance of blood. We need to check a lot of things, especially as we know, blood transfusion is coming as a medical legal aspect. So this is and it comes under the licensed product. So we need to be very careful and we need to be very cautious when we are ordering transfusion for blood component and any transfusion services. Safe Transfusion, WHO also launched one book on this. And the main objective of use of blood and blood products appropriately at all levels of the healthcare system in any country without compromising standards of quality and safety. The major focus areas are the appropriate use of blood and blood products, anemia, replacement fluid, clinical transfusion procedures, adverse effect of transfusion, and the most important is the clinical decision on transfusion. There are two things. One is the liberal transfusion strategy and second is the restrictive transfusion strategy. We need to be decide where we need to be use a restrictive transfusion strategy and where we are going to use liberal transfusion strategies. And transfusion in a clinical practice, and it must be the disease specific and requirement specific, because most of the time we are aware of especially in the dengue season, if a platelet count is coming down, so everyone is looking for the platelet, especially for RDP or SDP, even though patient is not required most of the time on the basis of the clinical history or clinical symptoms. And for this, WHO, especially in the 63rd World Health Assembly, especially in 2010, they adopted the resolution, and bearing in mind that patient blood management means that before surgery, every reasonable measure should be taken to optimize the patient's own blood volume, to minimize the patient blood loss, and to harness and optimize the patient specific physiological tolerance. So this is a very important aspect. Before as we are aware, when patient is going for the surgery, we need to take care of all the investigations, and before relying on the transfusion, first we need to optimize the patient condition for the anemia, especially those patients who are especially coming, if they are anemic, first we need to correct the anemia, then we go for the surgery. It is not like that if in any case of elective surgery, we admitted our patient and then we transfuse and then we are going for the surgery. First, we need to identify the cause for the anemia. First, we need to correct the cause anemia. Then we need to take the patient for the surgery. And on this, there are a lot of societies working on this. Society for Advancement of Blood Management, Network for the Advancement of Transfusions Alternatives, and Australian Association, and International Foundation of Patient Blood Management. These are the major societies who is working for the conservative transfusion strategy. And the safe patient, when we are talking about the safe patient, that patient blood management rule automatically comes. The main important thing, the presentation and diagnosis, therapeutic decision making, and knowledge, evidence, and principles. What are the problem-based clinical practice guidelines, personalized and focus, patient-focused medicine. Then PBM, normally it based on the important three important pillars. One is the first, we need to identify. Second, we need to prevent. And third is we need to optimize. So these are the three important pillars of the patient blood management. And as we know, this is all about the patient centricity. We should be more focused on the patient's own blood rather than allogenic blood. In view of that evidence case approach, it was published in the National England of Journal of Medicine in 2013, transfusion strategies for acute upper gastrointestinal bleeding, where they opted for the restrictive transfusion strategies when the hemoglobin level is 7 gram per dl, and it significantly improved outcome in patient with acute upper GI bleeding when compared with the liberal strategy transfusion. We are using these terms come frequently in this presentation. The restrictive transfusion strategy, when we are going to transfuse when the patient is having hemoglobin of 7 gram per DL, and liberal transfusion when the patient is having hemoglobin of 9 gram per DL. And basically, we need to be the product centric. And when we are comparing with the product centric and patient centric, initially it was used if a patient is having hemoglobin of less than 7, we need to be ordered 2 or 3 units of PRBC. But right now, single unit concept is in prevalent. We need to be transfused only 1 unit, then we need to assess, then we can go for the another unit as per the requirement of the patient. Again, in product centric, there are a lot of issue, fresh versus old. There's always debate and always debate on the fresh versus old PRBC, because stored RBC are having most of the time storage lesion. Those may not cause to expected increase in the hemoglobin, but there are a lot of debates on this, because blood comes under regulatory kind of things, and the shelf life of any PRBC, especially if I am talking about at our center, because we are using leukodepleted PRBC, is a 42 days, and it depends on the nature of coagulant which we are using. It might be 35 days or it might be 42 days, but it is better to use newer PRBCs because they are having less storage lesion. And when we are comparing whole blood versus component, rational use of blood components, so these all factors we need to keep in mind. And when we are talking about the patient-centric, either we are going to deal with the surgical patient or non-surgical patient, because the requirement may be different in the surgical patient and non-surgical patient. There are various stakeholders in the PBM. When I am talking about the various stakeholders, the first and most important stakeholders are the clinicians, then clinical support team, hematologist, transplant surgeon, critical care specialist, oncologist. So most of the clinicians are the important part of this patient blood management, then clinical pharmacist, nutritionist, then patient representative, medico-legal experts, public health experts, PBM implementation experts. These all are having very important role for the implementation of patient blood management. And this is a multidisciplinary and multi-professional unit. As I earlier mentioned, there are 3 important pillars of the patient blood management. The first and most important pillar is the detection and management of anemia and correction of mainly iron deficiency. The second important pillar is the minimization of blood loss and optimization of coagulation. And third and important pillar is the leveraging and optimizing the patient-specific physiological tolerance of anemia. And we need to be very judiciously use all the 3 pillars. And the concept of PBM first started from the Western Australia from in 2008, where the government of Australia ordered every tertiary care hospital to follow strictly guidelines of the patient blood management. And this program was associated with significantly improved outcomes, cost saving of many millions of dollars, and significant reduction in the blood product uses. And nowadays, PBM is one of the very hot topic in the transfusion services, because it not only reduces the cost, but it also reduces the length of stay in the ICU setup, length of stay after surgery. There are a lot of beneficial effect of these program of patient blood management. As we know, the global prevalence of anemia, blood loss, and bleeding disorder, when I'm talking about the pillar 1, which is dealing especially with the iron deficiency anemia and identification, 2.9 plus billion individuals with anemia are present, and we can easily correct by giving some kind of iron therapy or just iron therapy or some kind of food supplementation. And when we are talking about pillar 2 and 3, 600 million individuals with chronic or acute blood loss and or bleeding disorders. And this may be because of major surgery, medical and it may occur on medical and surgical ICU, GI bleeding, hemoglobinopathies. There are a lot of factors involved in this to correction of pillar 2 and pillar 3. That is the optimization and correction of bleeding and identification of the bleeding and cessation of the bleeding or correction of coagulopathy. The concept of rational blood use started not early. It was earlier talked in way back, more than 60 years back in 1950, where it was mentioned that in a very important journal, that was the blood, unnecessary transfusion poses a problem, and many of us deserve criticism for the way in which we have made this problem. And the reason for misuse of blood transfusion is that we are not sufficiently aware of what are valid indications for the procedure. Though this is a very true, most of the time, even the patient is having 10-gram hemoglobin, we are getting requests for the PRBC transfusion. But in our hospital, we are working as a team, and all the clinicians are very good. They understand this issue, and we are in the close conversation, and we are having very judicious use of blood. And we can say we are having very effective patient blood management program at our center. Then again, after in 1958, the second article was published in 1963, where they stated, and this is the article from the JAMA, where they stated blood transfusion is short, and two aspects are at play. The false assumption, modern laboratory methods are completely effective, and the popular belief that blood transfusions are tonic. I am stressing on these lines because these are the very important factor. We observe that even after many surgeries, clinicians are asked for the FFP. Even in spite of the normal coagulation factor, normal PT-INR, but they are using these products just for the sake of, as mentioned in this journal, this is a very reputed journal, transfusions are a tonic with capabilities of correcting mild as well as serious disturbance in surgical and in certain medical conditions. Then again, paper published in 1978, blood transfusion use and abuse of blood components. This is a very important paper. On the basis of this paper, there are a lot of program was made by the US government, by the FDA launched the program, and they decided, because this was the era when there was some transfusion associated infection was noted, especially for hepatitis C virus. And after that, they implemented some guidelines, and there was a mandatory testing after this paper. Now I'm talking about the transfusion practices during surgery. The use of blood and components in most elective surgery has decreased because of better patient management and use of meticulous surgical technique. The use of blood component in elective surgery varies greatly, and these variation depends on diagnosis, indications, difference in surgical technique. I have witnessed even in my hospital, initially we used to give 4 to 5 PRBC in the cardiac surgery, at least 10 to 15 PRBCs in the liver transplant surgeries, and 5 to 6 unit of PRBC in the renal transplant surgery. But at present, they are using very judiciously, and this demand is decreased up to sometimes there was no use of blood in the cardiac surgery and renal transplant surgery, and in liver transplant surgery, which was initially 10 to 15 unit, reduced up to 2 to 3 unit as per the clinical requirement of the patient. These are the two scenarios, especially where the journey of an anemic elective surgery patient in ICU setup, and where patient is not having any not diagnosed for the anemia. And the second step after the implementation for the elective surgery, where patient is investigated properly and counseled by the family GP doctors, and whenever consultation is required, it was given for the optimization of RBC mass before the surgery. And after the optimization, then patient is booked for the surgery. In spite of, when I am comparing with the scenario one, in spite of anemia, patient was booked for the surgery, and there was an unnecessary transfusion to correct the anemia for the surgery. Now it is changed up to the optimization of patient own blood by pharmacological agent, and after that the patient was booked for the surgery, and it gives drastic effect in the reduction of ICU stay, and it improves management of blood loss and or coagulopathy treatment of post-op anemia. Then I am comparing with the pillar 1. So pillar 1 is the start optimization, and pillar 2 especially deal with the minimization of blood loss and optimization of coagulation. As in previous talk, Dr. Sishti mentioned that malnourished is the one of the important factor which can increase the mortality after post-operative surgery. So if I am comparing with the that thing, so minimization of blood loss and optimization of coagulation is improved if we optimize patient before booking for the surgery by detection and management of, especially for anemia. And the third pillar, that is the leveraging and optimizing the patient specific physiological tolerance of anemia. We should not look for the specific lab requirement. If patient clinically requires transfusion along with the lab result, then we should ask for the transfusion request for the blood and blood products. Now I am talking about red cell transfusion in critical care. Anemia after admission mainly caused due to the hemorrhage, hemodial, because critical care is the one of the unit where they are dealing not only surgical, they are dealing with the medical patient, they are dealing with the surgical patient, they are dealing with the post-operative transplant patient. So a lot of things in the critical care, they must be aware that anemia after admission is mainly caused due to the hemorrhage, hemodilution, frequent blood sampling. Again, just last week, one of the paper published in the JAMA for the frequent blood sampling that may lead to the heterogenic anemia. We should avoid by small blood volume sampling and inflammation. Most of the time, these transfusions are given to correct low hemoglobin rather than treat active bleeding. So we should focus on to prevent the bleeding, then correction of low hemoglobin. Then these again guidelines for the red cell transfusion in critical care, and this was published by the British Committee for Standards in Hematology, and they suggested that if the hemoglobin is more than 9, so first we need to take, if patient is hemodynamically stable, we don't need to give any kind of transfusion. And if patient is not hemodynamically stable and hemoglobin is less than 9, then again we need to think as per our other factors, patient either in the severe sepsis or in neurocritical care or with the ischemic heart disease. And on the basis of these formulation or guidelines, we need to decide our transfusion request. FFP transfusion mainly indicated for the treatment of bleeding in patient with deranged coagulation due to deficiency of multiple clotting factors, and the dose is minimally 12 to 15 ml per kg, equivalent to 4 units in average adult. It is not indicated for prophylaxis in non-bleeding. If patient is not bleeding and INR is within a normal range, you should not prefer to go for the FFP transfusion after each and every surgery. And we should avoid, because when we are dealing with the blood product, there's a lot of hazardous thing we are giving, especially we are doing 5 mandatory tests in our blood bank. But in spite of that, there are a lot of things we can giving hazardous things in the transfusion. So we can avoid all these things by the judicious use of blood. Then cryoprecipitate again, if the fibrinogen level is less than 1.5, and if patient is in severe liver disease or bleeding, we can give fibrinogen, and especially we are targeting fibrinogen if less than 1.5 gram per liter. The most common blood product used to replace fibrinogen, but right now there's a lot of pharmaceutical products are available to correct fibrosinemia, and especially one product that is the PCC, prothrombin concentrate complex, we can use in the for the bigger surgery, or if patient is having a very deficient low level of level. Now I am talking few slides about the massive transfusion protocol, how to fix it. The option 1 is massive transfusion protocol, and now option 2 is massive transfusion avoiding protocols. And now we are using massive transfusion avoiding protocol, but because it ultimately leads to the switch for the massive transfusion protocol, it is also known as massive hemorrhage protocol, where we need to identify the culprit and we need to act on that in spite of giving a massive transfusion to stop the bleed, save life dictum for MTP. And basically, if I am talking about the treat first, what kills first, and sequence is the very important factor. Massive transfusion protocol is basically established to provide rapid blood displacement in a setting of severe hemorrhage. And there are so many definitions of massive transfusion protocol. When we are giving 10 units of red cell in 24 hours, or total blood volume is replaced within 24 hours, or 3 units over 1 hour. So you can decide on the basis of various definitions, are you going to deal with the massive transfusion protocol? Because massive transfusion protocol can save a life, and it requires multidisciplinary approach, because there are a lot of things required to activate massive transfusion protocol. Because as you know, FFP is always kept at -80°C, and for the thaw of FFP to 37°C, it requires near about 30 to 35 minutes. Then massive transfusion clinical settings, especially MTP protocol, is mostly activated in cases of trauma, surgery, especially in liver surgeries, and less frequently activated for the abdominal aortic aneurysm, liver transplant, and obstetric catastrophe, and GI bleeding. And one of the massive transfusion protocol is also activated in the obstetric, especially in ectopic ruptured pregnancies. The other challenges, the type of component to be administered and selection of the appropriate amounts at that time. And time is a very critical factor when we are dealing with the MTP protocol. And in that case, in emergency blood use, we can immediately give O negative PRBC. And in minutes, if we have time, it is always a good practice. We should type ABO and blood group. Then we should give group specific blood, because O negative is not always readily available. And if you have time, then we have to go give these products after complete cross match. And if unit are issued without cross match, written consent of physician to be taken, and complete cross match protocols followed after issue. And as I already mentioned, when we are dealing with the emergency release of blood, just again I am stressing on this point, when we are talking about the packed red blood cell, O negative is the universal donor, and when we are dealing with the plasma or platelet product, so AB is on the priority, then we can use A plasma or platelet. But for the emergency situation, O negative PRBC and AB positive or negative plasma or RDP product can be used for the emergency release. And the patient who sustained severe traumatic injuries and who are likely to require massive transfusion should receive 1 unit of PRBC, 1 unit of random donor platelet, and 1 unit of FFP in the ratio. And if required, we can give 1 cryo after correction of because it is a normal protocol of 1:1:1:1:1. But if the fibrinogen is more than 150, you can minus cryo, and after 1:1:1:1 in 10 packs, you can give at least 5 to 6 cryo in that ratio. And this is again the recent published data by the JAMA, where they suggested the ratio 1:1:1 ratio compared 1:1:1:2 ratio, where 2 is the RDP, and we are preferring 1:1. After 4, we can give 1 HDP. And we also used to damage control approach, where improved survival when the ratio of transfused FFP to platelet to red cells approaches 1:1:1. This was the published study, and they suggested if you use in this ratio, they will be the beneficial effect in the massive transfusion protocol. Just important at the onset, aggressive fluid replacement on bleeding control can reduce the tissue injury, inflammation, and hypoperfusion. Then untimely or complete control of massive bleeding, systemic conjunctive coagulopathy with hemodilation and endothelial damage. And if uncorrected, concurrent hypothermia and isostasis can further exacerbate coagulopathy and lead to multiple organ failure. Important is uncross-matched group O negative RBC or whole blood. Now there is a term low titer O whole blood can be used. Residual plasma with both antibodies can accumulate when large quantities are transferred. Repeat the blood group and do antibody titers before resuming transfusion of RBC of the patient's own blood group. These are the important factors we should keep in mind when we are dealing with the massive transfusion protocol. Again, these are the certain protocols template you can use at your own center. We are using at our center. We are making a template for the emergency MTP protocol. And basically, initial management of bleeding, first we need to identify the cause and initial measures, compression, tourniquet, packaging. These are the important measures for the initial management of bleeding. And cell salvage is the another way where we can use cell salvage machine to use patient's own blood. And the doses we should always keep in mind. We should always keep platelet count. If we are using RDP, we should always consider the platelet count. If platelet count falls below the 50,000, if INR more than 1.5, and if fibrinogen down less than 1 gram per liter, or it is better to use tranexamic acid to correct all these things. The complications of massive transfusions are hypothermia, acid-base descent, coagulopathy, citrate toxicity. I'm not going into detail because the main important factor when we are dealing with these protocols, we should always keep in mind PT and APTT are the very important tests for the coagulation, along with the platelet count, fibrinogen, electrolytes. And now we are moving towards the era of viscoelastic tests, which can guide the appropriate amount of appropriate product for the use of the transfusion. And we should always keep in the mind if we need to keep target hemoglobin more than 10, hematocrit more than 32, platelet count more than 50, PT should be always less than 1.5, PTT is 1.5 of the control, and fibrinogen should be always at given point for more than 0.8. So now just this is the last two slides. First, we need to keep in our mind, first, do no harm. That is the primum non nocere. That is the one of the main objective of any transfusion protocol. Either we are dealing with the routine transfusion or dealing with the massive transfusion protocol. Patient blood management and patient safety is one of the important cornerstone when we are dealing with the transfusion. And by viscoelastic testing in combat resuscitation, is there time for new standard? It is always a good practice. If we are dealing with any kind of transfusion, first we need to go to assess what kind of product is required by the patient for the transfusion. And now two assays, TAG and ROTEMS, are very important, commonly used. We are using TAG at our center, and which provide the accurate information on the coagulation process through the graphic display of clot initiation, propagation, and lysis, and used to guide transfusion of blood components. So now I'm going on the summary and recommendations. And first, we need to define protocol triggers and algorithm for preparation and delivery of blood products, including continued support. And the protocol should be updated annually and practice skill drills to inform and train relevant personnel, because this is a continuous process. Initially, when there was an era, they prefer for the whole blood. Now they came on the concept of component. Now there's a lot of paper is coming which again favors the practice of whole blood. This is the latest guideline published only last week for the red blood cell transfusion by the JAMA, and just the month of November. And this is the American Association of Blood Bank, which gives international recommendation, which suggests that we should always use for the restrictive kind of transfusion strategy, which stated if the hemoglobin is less than 7, then you can plan for transfusion. If hemoglobin is more than 7, you should always restrict your transfusion request. And keep calm and stop bleeding, because blood always gives some kind of anxiety, and especially during in the emergency or any rare traffic accident, there's a lot of confusion. Resident came by running, just give me blood, but we should be always keep calm. And first, we need to be focused on the cause of the bleeding. And yes, we are having all the protocols to deal with the emergency situation, but please be calm and stop bleeding, and avoid tocotalitrim and thrombosis by using judicious blood products. Thank you very much. Over to you, Dr. Anand. And I'm happy to take any questions if you have.
Thank you, sir. What a wonderful insight of the whole topic. It was really, uh, what I can say, an excellent presentation here on this platform. And I hope not only my surgical colleagues, surgery residents, but in fact, the anesthesia and critical care medicine, emergency medicine colleagues would be able to understand when to give, what to give, and how much to give. Thank you, Jaswal, sir. But before I conclude for this session, tutorial sessions, I would like to ask you a question. Sir, DIC, it's a common presentation
Yes,
in post-surgical and maybe in perioperative periods.
correct.
Does it needs correction of all the lab values, or we can stop at
Be-
like not to give, when to give?
DIC is a very double sword conditions. We always recommend we should avoid transfusion because we are dealing with the consumptive coagulopathy. Whatever you are going to give, it is going to be consumed. Okay, if you are giving platelets, it is going to be consumed. If you are giving FFP product, it is going to be consumed. The products, the factors. So it is better. First, we need to be yes. If we are again, this is a very tricky and very clinical condition. It depends on the clinical situation of the patient. So in that situation, first we need to identify the cause of. Suppose I am taking the example of obstetric cases. So in obstetric cases, the retained placenta is one of the important factor to causing DIC. So first we should focus on the primary cause, and then we should go for the transfusion. And yes, again, we need to be very cautious.
Thank you, sir. So with this, I would like to conclude today's tutorial, and I would like to thank firstly Dr. VK Kapoor sir for giving us a platform like this, where not only surgeons, critical care medicine, anesthesiologists, and the hematologists can share the various insights of various topics which we commonly share. And I would also like to thank our faculties for today, Dr. Pramod Satwa, Dr. Devin Juneja, Dr. Srishtijan, and RM Jaswal sir for taking out the time for this tutorial. And would like to extend my thanks to Dr. Nikhil Ajmera sir, who had a busy day today, had to attend some family function, and he took out the time to chair a session. And anything else to add, Ravi?
That's it. Thank you, Anand. I think we should conclude the session over here. But as you see, the last slide, never stop learning because life never stops teaching. So this session concludes with this note that whatever we have discussed in the last 2 days is just a tip of iceberg only. And you need to, like, we have books written on these five few topics. So you can dig in deep as much as you want. We tried to summarize as much as possible. Keep on learning, keep on achieving excellence. Thank you for us. I think we can stop here.
Thank you,
Thank you.
everyone, and good night.